Continuing the last video, first of all, I want to show what is storiform fibrosis. This is basically the pattern of storiform fibrosis. It is basically whorls and patterns of cells wholly there. It is seen in IG4 related disease, right? Now moving ahead, the fate of abdominal or thoracic aortic aneurysm could be either aortic rupture or aortic dissection. Aortic rupture is most commonly caused because of trauma, be it any accident or anything, or maybe a blow to the chest. So that can lead to aortic rupture. Okay, and the most common site associated is the abdominal isthmus, that is basically the descending aorta just distal to the origin of left subclavian artery, that is after all the vessels have originated near the area of ligamentum arteriosum. There could be a traumatic aortic rupture, and this rupture will actually be because of the tear in the intima and eventually tear in the entire 3 layers of the vessel wall. X-ray will reveal a widened mediastinum because of extravasation of blood. Now, moving to the more important topic, which is aortic dissection. Aortic dissection is basically a longitudinal tear in the tunica intima. As you can see over here, there is tear in the tunica intima, which is leading to extravasation of blood within the lamellar units of the tunica media. Basically, tunica media is arranged in a laminar fashion. Here there is intima. Suppose if the intima breaks, the blood will come and it will flow across the lamellar units of the tunica media. So this is basically known as aortic dissection. As you can see over there, there is characteristic spread between the lamellar units of the outer 1/3 of media, between the media and the adventitial layer. Okay. The most serious form of aortic dissection involves aortic valve and aortic arch, and the risk factors is males are more frequently affected than females. The age distribution is basically the patient usually presents around 40 to 60 years. If there is a young patient, we suspect a syndromic any sort of syndrome which is linked to it. Also in pregnancy, because of hemodynamic changes, the blood vessels are predisposed to dissection. Okay, one thing to be noted over here is aortic dissection is not seen with substantial atherosclerosis. Why? Suppose if there is atherosclerotic plaque over here, it is already very thickened. Where is the space to get tear in intima? It could not tear, right? And if there is medial fibrosis, as seen in syphilis, if suppose there is fibrosis over here in the tunica media, how, even if the intima tears, where will the blood go? The blood just cannot intrude the lamellar units of the tunica media. So basically, in case of a lot of atherosclerotic plaque is there, or if there is fibrosis in the tunica media, we will not see aortic dissection. Just eliminate it from your differential diagnosis. Okay, the longitudinal intimal tear which we talked about, there will be basically medial degeneration at the site of tear, and there would be the fragmentation and loss of elastic fiber. There would be mucoid extracellular matrix accumulation, and there would be tearing of the smooth muscle. Characteristically, aortic dissections do not involve inflammation. There is no use of inflammation as such, and also mostly inflammation will cause fibrosis and scarring and stuff like that. So the vessel wall over there itself becomes very thickened, so there is no scope for tear, right? It can be associated with hypertension, which is the most important risk factor. It can be due to bicuspid aortic valve. It can be due to any connective tissue disorder. Okay, these are the risk factors. Now, how will a patient present? A patient can present to you with a sudden onset of chest pain, which is tearing in nature. The patient will feel like something is getting ripped off apart in his body. This pain can radiate to the back, and there might or might not be unequal blood pressure in the arm, which we can measure. So first, if the left subclavian artery is getting involved, so the left side will have a different blood pressure than the right side, so there could be unequal blood pressures, right? The chest x-ray can show mediastinal widening, and the complications which aortic dissection can lead to is organ ischemia. Because there is dissection, there is no proper blood flow, there could be organ ischemia. There could be aortic rupture also, since the blood is already some damage, the blood is flowing, it is basically separating out the lamellar unit. It can also flow in such a high rate that it can damage all the 3 vessel wall, and it can extravasate outside totally. So there could be aortic rupture, and eventually this can lead to death. Okay, There is something known as double barrel aorta, which is important to mention over here. Now suppose there is dissection which has happened over here, okay, the blood is flowing over here. What if this blood flowing again damages the tunica intima and enters the blood vessel? So basically what is happening, there is this blood vessel, right? This is the lamellar unit of the tunica. There is tear over here, okay, so the blood is extravasate, it is flowing like this. Now it is flowing at such a high rate, after traveling some distance, this again causes a tear in the intima and again reaches the circulation. Basically this is known as the double barreled aorta, okay. This is actually beneficial. Why is it beneficial is, it basically is forming a false channel sort of, and it is basically it is preventing the spread of dissection firstly, and the second thing is, because of this channel formation there will be endothelium formation all across. So basically there will be formation of false channels, and this high velocity of blood pressure, it will not cause aortic rupture as such. So this double barrel aorta is basically, it is preventing a fatal hemorrhage. This endothelialization can cause a chronic dissection, which is better than a fatal hemorrhage, right? So basically double barrel aorta is beneficial. Just remember this thing. Okay, this is how aortic dissection appears. There is hemorrhage over here, you can see, between the lamellar units of the tunica media. This is a histopathological image of the aortic dissection. Now the aortic dissection, we basically have two types of classifications which classify it: a Stanford classification and the DeBakey classification. The DeBakey classification distributes the abdominal dissection into three types: type 1, type 2 and type 3. Type 1 involves the entire structure of the aorta, okay. Type 2 involves only the proximal intimal tear. Basically type 1 is, there is tear in the proximal region, okay, but the blood is extravasating all throughout. Type 2 is, there is again tear in the proximal region, okay, but the extravasation of the blood is also restricted only to the proximal region. The third type is basically, there is tear in the distal region and the extravasation of the blood is subsequently in the distal parts, okay. So these are the three classifications by DeBakey. Combined type 1 and type 2 DeBakey, where the tear is basically on the proximal side, is known as type A Stanford. It is type A in the Stanford classification, and the distal tear is basically type B in the Stanford classification. Why are we basically classifying is, the treatment for Stanford classification A is different from type B. Type A is, the definitive treatment is surgery, okay, and for type B the definitive treatment is not definitive treatment, but the line of treatment is beta blockers, and then we give vasodilators. Type A, you can remember A for ascending, so it basically is involving the ascending aorta, and B comes after A, okay. So it is below the left subclavian artery, that is the distal or the descending aorta, okay. Type A is also is a risk factor to acute aortic regurgitation and cardiac tamponade. So we have learned everything about aortic dissection. Just summing it up, it is longitudinal intimal tear, as you can see over here. Basically the blood enters the lamellar units of the tunica media and flows across it. Aortic dissection cannot be there in significant atherosclerosis or medial fibrosis, that is for example in syphilis. In histopathological staining, we can see elastic fibers defragmentation and loss. There could be smooth muscle tear, and there could be accumulation of extracellular matrix. There is no inflammation. The most important risk factors associated with aortic dissection is hypertension. The patient can present with sudden onset of chest pain radiating to the back and unequal blood pressure in the arms. Chest X-ray reveals mediastinal widening. Complications are ischemia, aortic rupture and death. There are two classifications which classify the aortic dissection: DeBakey and Stanford. In DeBakey there are type 1, type 2 and type 3. In type 1 and 2 there is proximal tear. Type 1 proximal tear leads to the flow of blood, the extent of blood throughout the aorta. Type 2 there is injury to the proximal part, but the flow of blood is restricted. In type 3 the intimal tear is in the distal or the descending aorta. Type 1 and 2 combined give rise to type A of the Stanford classification, which involves proximal tear which is in the ascending aorta. Type B involves distal intimal tear, which is basically the descending aorta. Type A, the definitive treatment is surgery, whereas in type B we give beta blockers and then vasodilators. So thank you.